Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios. Hernias are a common condition, abdominal condition for that matter, that can affect people of all ages. But what exactly are they, and what are the health risks associated with them? Joining us today to talk about hernias, the causes, symptoms, and treatments is Dr. Anthony Gonzalez, Chief of Surgery at Baptist Hospital of Miami. Welcome, Doctor.
Thank you, Olga. Thank you for having me.
Thanks for being here. I love the bow tie.
Thank you.
You look fantastic. All right, so before we start the discussion on hernias, I do want to talk a little bit about you and something that you do that's very special. And we have a great story on the doctor, but real quick, you go to Haiti and you help a lot of people there. Why do you do it?
Well, because I have a Haitian background in me. My mother's Lebanese, born in Haiti. And so as a child, I spent many summers in Haiti, and I always wanted to give back. And so 12 years ago, we created our first surgical mission. We've created a team. We've gone over the last 12 years and done thousands of surgeries.
I love it. And giving back is what he's doing. We have a short video talking about the work he does as a surgeon and the quality of life and how he plays a role in patient care there. Take a look.
I am Dr. Anthony Gonzalez. I'm a general surgeon. Empathy is important because if you're not understand what patients are feeling, then I think you could really limit your ability to help them. Over the last 10 years, we've been taking surgical teams down to Haiti to do surgery. We travel with a team of, could be general surgeons, could be urologists, ophthalmologists, because giving, to somebody else gives you so much satisfaction that you felt that you've been given. When a patient comes to Baptist Health Medical Group, I expect them to experience the best care that they've ever seen. I expect that they will see a compassionate physician who will listen to their needs and help them coordinate their care. I think quality of life for my patients is what they feel their quality of life should be. If the patient just wants to survive and live and be cured of cancer, I'm going to do everything that I can within my power to help them accomplish that goal.
I think that's so fantastic. And the mission is unbelievable because they literally take everything there to Haiti. They have nothing. And you're bringing not only the team, but equipment as well, right?
Right. We bring, 50 to 100 duffel bags filled with all the medication, all the equipment, all the supplies to be able to perform those surgeries.
And you do a lot of hernias as well, correct?
We do a lot of hernias there, yes. Probably 50 to 80 over a weekend.
Wow, it's non-stop, a 12, 15-hour day.
Exactly.
But when you leave, you must feel just...
More satisfied than fatigued, definitely.
That's fantastic. All right, so let's talk about hernias. What exactly are they, and how often do you see them?
Well, hernias are very common. We see hernias, about 1 million hernias are repaired a year in the U.S. And hernias are seen in everyday practice. No matter what type of physician you are, you're going to see them. Of course, in my area of expertise as a specialist, I see a lot of hernias. And the simplest way to understand a hernia is it's a hole. I tell our students that think of hernia H, whole H. Hernia is a hole. It's just a hole in your abdominal wall or in your groin where your insides are protruding through that area.
And it's painful.
It can be painful.
That I know.
It can start with some discomfort, and then it can progress to pain, of course, with strangulation. We'll talk about that in a little while. But of course, yes, you can have really, really bad pain with hernia.
We have a 3D image of an abdomen, and Doctor, I'd like you to walk over to our 3D wall, and this will kind of help you understand where it's located and what exactly is happening in the abdomen. So take it away, Doctor.
Yeah, so what you have here is an image of the abdominal wall. You have the musculature of the abdominal wall. We're going to be talking about groin hernias, which occur down here in the inguinal groin location. We're going to be talking about hernias that occur in the belly button, which is the umbilicus, and hernias that occur after surgery as well, which is incisional hernias. And as you peel away the abdominal wall, and you can see that as the abdominal wall goes away, then you definitely will see what is the layers of the abdominal wall, and then eventually you see the insides of the patient, and that's what is protruding through the hole.
And when it's protruding, we're talking about what, a couple inches out? It's like almost, I want to say like, tell me if it's like a golf ball or a tennis ball protruding out.
It could be anything from as small as a golf ball. It could be as big as a tennis ball. It could be as big as a cantaloupe.
Oh my goodness.
We can have patients that have a lot of their guts really spilling out of them. So yes, various sizes depending on how long it's been there and how how progressed is the disease process.
And I know there are several different kinds of hernias, but tell me if I'm right. I've seen people sometimes wearing this contraption, if you will. I'm going to try to stand up a little bit here. It goes on the side, and it's like pressure in the front and pressure in the back and pushing it in. Is that what they use to help with that pain?
Yes. So that's medical treatment. That's when somebody cannot have surgery. When somebody cannot have surgery, then they'll go on to medical treatment. You're talking about abdominal binders and trusses.
Right.
Abdominal binders help with the ones that are in the abdomen, umbilical or incisional hernias, and then they wear trusses in their inguinal or groin location when they have hernias that, number one, they can't seek medical care, they won't seek medical care, they may not have insurance, things like that, and people will begin with medical treatment, which is really non-surgical therapy.
It's almost like a Band-Aid, if you will.
Correct.
All right, so we do have a list of different kinds of hernia that we're going to be discussing today, so let's take them, doctor, and discuss them one by one. Let's take the first one.
So inguinal hernia is the most common type of hernia that exists. That's a hernia that's in the groin, in the inguinal location. A little bit below that is the femoral hernia, which is just below that. Femoral hernia is more common in women, though women will have more inguinal hernias. Umbilical hernia is what we call a belly button hernia. A little belly button hernia is an umbilical hernia, more common in kids, and a baby can be born with an umbilical hernia. And then incisional hernia. An incisional hernia is anywhere you've had an incision. So the moment that you have any surgery, you've had an appendix, you've had a gallbladder surgery, you've had a hysterectomy, in that area where the surgeon made the incision, opened your abdomen and closed you, there's at least a 20% chance that you can develop a hernia in that location, and that is called an incisional hernia.
We have an image of an umbilical hernia, which you said can happen in kids or in babies for that matter. I was surprised to hear that. Let's take a look at that picture, and so it's bulging out.
Correct. So a lot of parents will think of it as a deformed belly button. It's an outie versus an innie, as you can see.
I have an outie.
Well, then you may have a hernia.
Really? Well,
yeah.
But it's just an outie.
Okay. So, but anyway, that's what we have to look at. And so you notice that the belly button is kind of a little deformed.
Okay.
And
so it's larger than normal.
Larger. It's more protruding out versus in. And so that is an umbilical hernia. It can occur, of course, in babies. It can occur in children, adolescents, and of course, it can occur in adults as well.
And if one is not realizing what's going on, it can continue to grow?
Correct. And that's what will happen. See, what happens as the years progress and you get older, the tissues get weaker. The intra-abdominal forces that we're going to talk about in a little while that lead to progression of hernia, that will allow the hernia to grow with time. It'll go from a small little belly button hernia over to a big one. It'll turn into a golf ball and eventually an orange-sized ball.
Is this by chance or hereditary?
So it's a combination of both. Of course, the incisional hernias occur because you've had surgery, but the ones that you are born with, like an umbilical hernia or a baby that's born with an inguinal hernia, it is it is something that's coming from birth.
We have risk factors to look out for in case you are at risk for hernias. Let's take a look at some of these. Male gender, really?
Well, it's just that hernias are more common in men.
Okay.
And so that's what it is. But I think the basic principle that you have to take back is anything that would increase your pressure in your abdomen. So, of course, pregnancy, which increases your intra-abdominal pressure. Obesity, when you have a lot of fat inside your abdomen as well. Smoking, because of the chronic coughing. So smokers have a chronic cough, and if you're coughing all the time, you're increasing your intra-abdominal pressure, and that, of course, will lead to hernia or allow your hernia to progress much more rapidly. Those who have constipation, whether they have just chronic constipation because of colonic disease or because, God forbid, they have a tumor in their colon or something like that, they can lead to as well to a hernia or progression of a hernia. Maybe you have a small hole, is what we call subclinical, a small little hole in your abdominal wall, not really noticed, but because of the coughing and because of the straining, it progresses over years and then it becomes evident.
I also know that when you go to the gym, I'm not a gym girl, but when I used to go to the gym, I used to always hear trainers say, be careful when lifting, you don't want to get a hernia. What does heavy lifting have to do with that?
The same reason, because you contract your abdominal muscles, you're increasing your intra-abdominal pressure, so it does the same. But we've learned through the years that you're more likely to have a back or a orthopedic injury at the gym, and God forbid some type of heart problems at the gym before you're going to have a hernia.
I've also heard of one called, if I say it incorrectly, please let me know, doctor, hiatal?
Hiatal hernia.
Hiatal hernias. Okay, what are those?
So hiatal hernia is something we're not going to talk about today. We're going to talk about on another show. But a hiatal hernia is a hernia that occurs in the chest. So it's your stomach that moves up into your chest.
Really?
And that causes reflux. It can cause strangulation, difficulty in eating. And so that's not something that people notice. Patients will come and say, I have a hiatal hernia. Look, well, you can't see it on the outside because it's the stomach that's protruding up in the chest. That leads to more symptoms like reflux, difficulty eating, difficulty with digestion, and that's what a hiatal hernia is. Different problem altogether, dealt with much differently, and that's more of an intestinal, gastrointestinal problem.
Would you say this one is a little bit more difficult to treat or difficult to deal with than the other?
Well, it just depends. No, they're all, yes, inguinal hernias and umbilical hernias are going to be easier to, to treat and operate and so forth. They're less complex, but, when you have experience, the hiatal hernia repairs are quite simple as well.
Fantastic stuff. All right, up next, we're going to take a quick break, and then we'll be talking about what symptoms you may feel when you have a hernia and how hernias are diagnosed. You're watching the Health Channel, all health, all the time on South Florida PBS. If you have a question for Dr. Gonzalez, please call us using this toll-free number, 855-796-4475, or visit our website, allhealthtv.com. You can watch previous videos from previous episodes, and we will be right back with hernias.
The city of Newark, New Jersey recently reported high lead levels in the water of thousands of area homes.
Drinking water often takes a long journey after it leaves local treatment facilities, potentially picking up a number of unwanted contaminants along the way before it gets to your home.
In an effort to help the Newark community, Pure has donated almost $500,000 worth of filtration systems. Pure's faucet filters remove 99% of lead and reduce over 70 other contaminants. Learn more at pure.com.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Us lives here, where we can find common ground, big enough to dance on. For a better us, support your local Y today.
Addiction is a dark place, but just as each new day breaks, there's light. A light that illuminates the people by your side. Out of the darkness, you are walking with 22 million others struggling with addiction. The cure to darkness is light. The cure to stigma is love. And the cure to disease is treatment. Join us as we walk into the dawn of a new day. Together, we are stronger than addiction. Learn more at chatterproof.org.
Welcome back to the Health Channel, all health, all the time. I'm Olga Villaverde, and with us is Dr. Anthony Gonzalez, Chief of Surgery at Baptist Hospital of Miami. If you have a question for the doctor, please call us using this toll-free number, 855-796-4475. We would definitely always love to hear from you. So let's talk about what symptoms people might experience when they have a hernia. The symptoms vary from person to person, but these are some of the common ones, doctor. A lump in the abdomen or groin. So it's kind of obvious. It's not as if it's just a little thing. thing there. You're like, okay, this is getting bigger.
Right. So some patients will come in and say, hey, I feel something. They may not have actually any symptoms per se. In other words, any discomfort, any pain, but they may say, I feel something in that area. I feel a lump. I feel a ball. It comes and it goes. Very commonly when I'm showering, I notice it in my groin. When I wake up in the morning, it's gone because they've been resting all day.
That makes
and
sense.
Everything that was protruding out has come back into the abdomen. So really, if you're not an expert, you're not going to feel the hole. Remember I told you in the first segment that it's a hole. You're not going to feel the hole. What you feel is what's protruding out of the hole. And so they may feel a lump. Of course, as they progress, they'll tell you, hey, as my day progresses, as I do exercise, as I'm on my feet all day, I feel pain, I feel pressure in that area. And so that'll be a second symptom. Of course, they can also feel burning. Why? Because if it impinges on any nerves in that area, then you'll have the burning. And then, of course, as it progresses, the pain will intensify. The pain will become steady. And then it'll start affecting their activities of daily living, and they'll have difficulty with doing just daily activities. And so that progresses as the hernia gets bigger.
So as you start experiencing these symptoms, is it fair to say that at the beginning you're going, what is this? And then it just progressively starts getting worse. You really just don't figure it out immediately.
Correct, yeah. I think what happens is people notice a lump, they get concerned, people think about the worst things in the world, right?
That was my next question.
Right, I have a tumor, God forbid. But when you wake up in the morning and it's gone, you say, it can't be a tumor, it can't come and go.
Exactly.
So, you're really, intelligent enough to understand that. And then as it starts impeding on your life and it starts impacting your daily living and your activities and your weekend warrior kind of things, then yeah, you start seeking medical attention.
You might hear a doctor say that a hernia is incarcerated. What does that mean?
So incarcerated is kind of like being in jail. It's stuck.
I was going to say it sounds
Right.
like being behind bars.
It is. It's stuck. So in other words, the lump doesn't go away. In other words, you lay down and you wake up in the morning and the lump is still there. And so that means that whatever is protruding out is stuck in the hole and it doesn't come and go. And of course, that's dangerous because whatever is stuck in that hole is kind of being cut off from the rest of the abdomen. It's losing its blood supply and it can progress to strangulation. And strangulation is when you lose the blood flow and things start dying. So it's basically like putting a really tight ring around your finger. Eventually, with time, the tissues will die because of the pressure in that area. And so, yes, if you notice you have a lump and it doesn't go away, number one, you're worried about the worst, that God forbid it could be some type of tumor or growth, but also if it's a hernia and it's strangulated, then that's concerning as well because of course that can lead to strangulation, can lead to an emergency, can lead to obviously real serious health complications.
I wanted to follow up on that because you used the word things are dying. So what things in the area could be dying?
Right, so it could be simple as just a piece of intra-abdominal fat that's being stuck in the hole. God forbid it could be a piece of intestine. That, thank God, doesn't occur commonly, but when it does occur, it's going to lead to medical care immediately because if your intestines are stuck in a hole, they're blocked. Then comes the symptoms of nausea, vomiting, abdominal pain. So even though you have a hernia in the groin area and you have a piece of intestine stuck in that groin, you're going to start developing abdominal pain, nausea, and vomiting, and people within hours will lead themselves to the emergency room to seek care.
So there are hernias, shall we say, and then there are hernias.
Yeah.
Okay, which means sometimes they're pretty simple to treat, but sometimes they can really get dangerous.
Correct.
In many situations.
We can see our hernias, we can see patients with hernias in the office where they just have symptoms and they have difficulty with their daily living and they're playing tennis and golf, jogging. But then we have people that present with hernias who are strangulated and become a surgical emergency. In other words, they have to be in the operating room in a few hours.
Can they be serious if there's no symptoms at all?
Well, no. Usually you're going to have symptoms.
Okay.
Yes, you're going to have symptoms, whether it be minor symptoms or major symptoms. But yeah, it only is serious when it becomes strangulated.
Can it rupture?
No, so hernias don't rupture. They become strangulated and the tissues die and leads to infection in that area and it can become complicated, but no, rupture does not occur.
So what can one expect? Like, let's say a viewer out there says, well, I think I have a hernia, and they go see their doctor. What can they expect from that visit?
So usually what the doctor will do is first examine them. So examination is the first thing. And a lot of times patients will ask me, well, don't you want to do a test? Well, if I see a bulge coming out, I lay you down, the bulge goes away. I, as an expert, can feel actually the hole where the bulge comes through. Then that's simple enough. We don't need any testing. We don't need ultrasound. We don't need CAT scan. That's enough. So when you go see a doctor, whether it be as simple as your primary doctor or a specialist like us, you're going to get an examination. Now, if it's not evident, it's not clear, patients have symptoms and the hernia is you cannot palpate it, because maybe the patient's obese and you can't feel the hernia, then you'll proceed with testing. Sometimes testing could be as simple as an ultrasound, sonogram, or it can be a little more complex like a CAT scan of the abdomen, and testing will be done to help diagnose that hernia.
All right, and there are non-operative treatments. We talked about one that I told you that I've seen some people use, which is that, what was it called again?
An abdominal binder.
An abdominal binder.
There's an image of an abdominal binder. So that is good for hernias that are in the belly button or in the incisional location, which are in the mid-abdomen. And then there are also trusses. Trusses are binders, but for the groin area. They're a little more complicated.
How do they look?
So they are similar like that, but they're not only over the groin, but they come around between the legs as well to maintain pressure as the hernia comes through the inguinal location, and especially men, it projects and it proceeds down to the testicular and scrotal location. It puts pressure from below above. So it's pressure not only from the front, but from below as well. And they come through the front and they have some wraps around the back as well. And those are called hernia trusses as well. So people who don't want to seek care, don't have insurance, not sure what they want to do, anything, maybe they just had a recent heart attack, God forbid, and their doctor tells them it's not time to have surgery, we can start with a truss to help maintain everything inside the abdomen and prevent any strangulation.
And it's amazing how once they wear that, the relief is just so immediate. I remember my father had a hernia, and once he would put his hand right there and just push in, he'd be like, oh, that feels really good. Yeah. And it's just kind of immediate, just pushing it in.
Right, because what you feel is the pressure of the insides coming out. You feel the pressure of your guts or the fat inside your abdomen, which is putting pressure and giving you those symptoms. And so once you reduce the hernia, that's called reducing the hernia, and putting the contents back in, there you'll feel immediate relief.
What about a child? Can they also wear those, what we'd called trusses and corsets and
yeah, usually in children it's not necessary. They can, not common. Usually in children we proceed with repair at the appropriate age because we know they have a long life in front of them, and especially in young girls, you do not want them to become pregnant with a hernia because, as we talked about earlier, the intra-abdominal pressure and a growing fetus inside the abdomen will progress and make a hernia much more complicated.
Oh my goodness.
God forbid a pregnant woman becomes incarcerated or strangulated during a pregnancy, complicates the mother, complicates the birth, the child, the fetus. So because of that, children's hernias are usually taken care of. Young adolescent women, the rule of thumb is they have their hernia repaired before they reach adolescence and they have their first menstrual cycle. So God forbid they become pregnant, it's taken care of and they don't have to deal with that during pregnancy.
Have you ever dealt with a patient that had that during pregnancy?
Yes, we have. We have.
My
yes.
Goodness.
Yes.
How do you do that?
So we do it very carefully.
Obviously.
Of course. And sometimes we do them under regional anesthesia, which is like spinal anesthesia, epidural. Sometimes if it's an emergency and there are guts involved, then we have to do them under general anesthesia. But of course, there's monitoring of the baby sometimes before, during, and after. And of course, we're concerned. We have always the obstetrician involved because we want to make sure they don't go into preterm labor. They don't start their labor a little early and deliver a baby 20 weeks, 25 weeks, which of course will bring complications.
Is that common?
It occurs. Thank God it's not common.
Oh, thank goodness.
Thank God it's not common, but it occurs.
But usually very successful.
Correct. Yes, of course.
That's good to hear. All right, so we've been talking a lot about hernias and how they're diagnosed. So now let's see this in action. We have a video of a mock patient visit that shows what may happen when you have an incarcerated hernia. That's like being behind bars. Take a look.
Dr. Nake, just got your page. What seems to be the problem?
Dr. Pandian, your patient Gus looks like he's an abdominal wall hernia. It might be incarcerated. He's in room 3.
Incarcerated abdominal wall hernia. Okay, let me go take a look.
Sounds good.
Gus, sorry to see you in the emergency department. Are you in pain? Okay, let me take a look at your belly. Well, there's that bulge. I'm gonna push on this a bit. You let me know if I bother you too much. Fortunately, I think Dr. Nake was right. You have an incarcerated hernia, Gus. We need to make sure this doesn't become strangulated. Do you know what either of those words mean? I'll take that as a no. Let's talk to an expert who can tell us more.
A hernia is nothing more than a hole. Tissue pooches through some sort of space where it should be contained. Usually in the abdomen, that's the omentum or potentially the bowel or bladder, and that can be dangerous. It's more common in men than in women, maybe 800,000 inguinal hernias in men, and then incisions. When people have operations on their abdomen, at least 100 or 200,000 will develop hernias every year in the United States. Key thing to know about is when that tissue pops through and pops back, there's no real danger. When it gets stuck, that's called incarceration. As long as it's not an important structure and we haven't lost the blood supply, that's even okay. But if we get something stuck, like my thumb is losing blood supply, that's called strangulation, and that's a dangerous problem. So if you have a bulge that's painful and causing problems, you need to seek a physician immediately.
So is there anything you can do to prevent this problem? And what should you do if you develop a bulge like Gus?
The biggest risk for a hernia is being a man. 1 in 4 men will develop a hernia in their lifetime, usually in the groin or near the belly button. If you've had an incision on the abdomen, that puts you at greater risk. Other things that cause problems, smoking, lots of coughing, constipation, that puts exertion or emphasis on the abdomen and likely to develop more hernias. If you develop a hernia, it's usually not life-threatening, but you should see a physician. Most patients get these fixed, simple outpatient surgery, safely done.
Well, Gus, sounds like this problem isn't always preventable. Let's see if we can't reduce or push this hernia back into place for you. Nurse Upram, can you give Gus some pain medicine, please? All right, Gus, I'm going to start pushing on the bulge. There, we got it. This hernia that was incarcerated now is not. We've been able to temporarily reduce it. Unfortunately, this will most likely come back, so you'll need to have this fixed definitively with an operation. Do you understand? Great. You did the right thing, Gus, by coming to the emergency department right away. Now let's see about getting you home.
Are your patients a little bit more vocal than Gus?
They are.
I think
They
so,
are.
right?
Yeah.
I think I would be.
They speak English and Spanish. And in Haiti, they speak Creole, so yeah.
I love it. Okay, there was a couple things that came out of the video that I wanted to ask you, doctor. Number one, he pushed it back in. Obviously, Gus did not react, but when he pushes it back in, does the patient react like, oh my gosh, or is it like a, oh, thank you?
Yeah, so I think what you saw there in the video is something very important that you may have not noticed, is that they ask for pain medication. And so what we do in the emergency room when somebody comes in with a strangulated hernia is we examine the patient, we confirm there's a strangulated hernia, and then we ask for pain medication. Number one, to help with the patient with the pain, of course, the procedure of reducing the hernia, kind of like putting a bone or a joint back into place, is going to be painful, and it relaxes the patient. So that's the first thing. So of course, the patient will have discomfort, will have pain, will feel pressure when we're reducing it, and then when we push everything back in, they will feel relief, an immediate relief, and of course that deals with the emergency of the situation.
I also noticed in the video there was an area that was purple. First it was red, and then the one on the right was purple. Is that blood supply?
Right. So what you're seeing is on the left side, you're seeing normal colored intestine, which is pink, peach color. And then, of course, as it loses its blood supply, it becomes purple and eventually will turn black. And so if you hold pressure on your finger for a long period of time,
it gets purple.
It turns purple. Of course, you let go. You don't want it to turn black. But, of course, with time, it'll progress into black. And that's ischemic intestine, where it's losing its blood supply, is purple. And then dead intestine is black. And so, of course, those that we can't reduce and we can't push back in the ER go from the ER to the operating room. We operate on them, and then we actually make the hole a little bit bigger to push everything back in. And at that moment, we determine whether that intestine is viable. Can it survive? If it can survive and it recovers its blood supply and becomes pink again, then of course we leave it alone. God forbid it's black and it's dead, then we have to remove that segment of intestine.
All right, and the last thing I heard was 1 in 4 men. Wow.
Very common.
Very, very common.
Yeah, you know, I think what's even more important, it's never thought of in women. So a lot of times in my office, we have somebody who comes in, it's a woman that comes in with pain in the groin, pain in the lower abdomen, pressure, back pain, and nobody ever thinks about a hernia in a woman. And it occurs in women as well. And it's hard to diagnose. They may not feel a bulge. Yes, grandma will feel a bulge when she's 90 pounds and she feels a little lump in her groin, but the everyday woman won't feel a bulge. So that's why testing and ultrasounds are very important in a woman who has symptoms to make sure they don't have a hernia.
All right, we're going to take a quick break, but when we come back, we're going to be talking about how hernias can be repaired surgically, including minimally invasive techniques like robotic surgery, so common today. You're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for Dr. Gonzalez, please call us using the toll-free number 855-796-4475. And please be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel. That's right, a live stream right now. Also submit questions for the experts and watch videos from previous episodes. We'll be right back.
1945 to 1965. People born during these years are 5 times more likely to have hepatitis C, a leading cause of liver cancer. And people can live with hepatitis C for decades without any symptoms. The good news? Now, treatments are available that can cure hepatitis C. So if you were born from 1945 to 1965, talk to your doctor about getting a blood test for hepatitis C. It's the only way to know.
Everyone deserves a decent place to live.
Everyone.
When a future homeowner partners with Habitat for Humanity to build or improve a home, they build a better future for themselves and their families.
For my family.
For my family.
For my family.
With a little help, we all have the potential to stand on our own.
Potential.
Visit Habitat.org to provide help to families like these today.
C stands for courage, collaboration, compassion, and sometimes even cuddly. At Miami Cancer Institute, C also stands for Cure, world-class cancer care right here at home. Learn more at miamicancerinstitute.com.
Overuse and misuse of antibiotics promotes the development of antibiotic-resistant bacteria. Every time a person takes antibiotics, sensitive bacteria, bacteria that antibiotics can still kill, are wiped out. But resistant bacteria are left to grow and multiply. Though antibiotics are completely ineffective against viral infections, like the common cold, flu, most sore throats, bronchitis, and many sinus and ear infections, they are still commonly and wrongly prescribed. Smart use of our antibiotics is key to controlling the growth of resistance. It's estimated that of those patients who visit an outpatient provider in the United States, over half of antibiotics prescribed are inappropriate.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Anthony Gonzalez, Chief of Surgery at Baptist Hospital of Miami. If you have a question for the good old doctor, you can call us using the toll-free number 855-796-4475. We would love to hear from you. Okay, so let's discuss hernia surgery. First of all, when is surgery? Yeah, you gotta get surgery immediately.
Well, you of course got to get surgery immediately when you're strangulated in the emergency room, like we saw in that video. So if somebody is strangulated in the emergency room and cannot be reduced and pushed back in, then you go straight to the operating room. You also need surgery if you have a strangulation, it's pushed back in, and as they mentioned in that video, you need to have eventual surgery. Sometimes it means that you're admitted, you're brought into the hospital, the doctors check on your heart, your lungs, and you're kind of cleared and you have surgery in a day or 2 days. Sometimes it means you go home and then we schedule your surgery as an outpatient. So those are kind of the immediate situations in regard to having surgery. And then the patients who have symptoms. We talked about pain in the groin and swelling and discomfort. Those patients that come and see us in the office and where the hernias are impacting their life, then those patients should have surgery as well. Of course, if you have medical care access and you, of course, are a candidate to have surgery, in other words, your primary physician feels that you can have surgery because of your medical conditions are stable, then you really should have surgery.
Let's bring back that graphic that we had earlier on the different types of hernias. And doctor, walk me through to tell me, with each of these cases, how the treatment and surgeries might differ.
Yeah. So, of course, you know, whenever you can, you should have minimally invasive surgery. And we've learned that through the years since the late 80s with gallbladder surgery. We no longer open patients to have gallbladder surgery. We do it with 3 little holes. And so the same applies with inguinal hernia. And so, of course, thank God at Baptist Health, we have experts like myself who do minimally invasive surgery for hernias. Now, if you're in a small town, you may not have a surgeon that can perform minimally invasive hernia surgery because it's more complex than a gallbladder surgery. And so any of these hernias, if it's possible, should be done in a minimally invasive fashion. So inguinal and femoral hernias are in the groin location, and those are done with small little holes. Umbilical hernias are in the belly button. Now, of course, if the hernia is small and you're a thin individual, it may be done with small little cut, and so it may not need the minimally invasive approach. And incisional hernias, sometimes they are amenable to minimally invasive approaches, and sometimes hernias are so big that you can't do them in a minimally invasive fashion. So there are limitations still to what we have. Though there's been a lot of progression in technology and advancement in surgical care, there is limitations, and so not all hernias are amenable to minimally invasive surgery.
So sometimes you have to make the call that, no, I can't do robotic surgery here?
Correct, yeah. And so sometimes it's evident when you see the patient in the office. Sometimes it requires some testing, like a CAT scan, to determine that, and you bring the patient back and you discuss it and you show them the images. But yes, sometimes it's not amenable to robotic surgery.
All right, and how has that surgery evolved over, let's say, in the last 40 years of what we did and where we are today?
Right. So in regard to minimally invasive surgery, that's been around since the late 80s, and the adoption of gallbladder surgery. Robotic surgery, which is an advancement of laparoscopic or minimally invasive surgery, has been around since 2000, was developed for heart surgery, really never really succeeded in the heart surgery, and became standard of care for prostate surgery. So really now in the US or any other developed country where you're going to have prostate surgery, you're going to have it done robotically. That progressed into robotic surgery for gynecological conditions, and now more recently we have been leaders in implementing the robot for hernia surgery and been teaching other surgeons around the country and the world how to do hernia surgery with the robot.
And sometimes you use mesh to do some repair. Can you explain that to us?
So let's go back to the principle of what a hernia is. A hernia is a hole, right? So we need to close the hole. And you think in simple terms, let's just close the hole with sutures. Well, the problem is about 60% of the time the hole will open up again. And so it was developed that we use a piece of little plastic. It's like polypropylene, which is like plastic from PVC piping, but very thin. As you can see, the sheet of mesh on your image, it's like the screening around a pool. That piece of mesh is placed in the area of the hernia. That creates an inflammatory reaction and a scar. And the scar is what heals up the hernia. And so that's why mesh. Now, I told you a chance of a hernia coming back with sutures, 60%. With mesh, less than 5%.
Oh, wow.
So it revolutionized what we did in hernia surgery. So nowadays, if your hernia is bigger than like an inch in size, 1 inch, then you probably should be having mesh placed to decrease the chance that a hernia can come back.
And just to make it clear, this is repairing, this is not like an appendix. Like my father took out my appendix. I don't have an appendix. We're not taking out the hernia, we're repairing it, right?
Correct. We're repairing the hernia, we're fixing the hernia. So I had a patient the other day, the son said, did you remove my mom's hernia?
Right.
No.
A lot of people say that.
Correct. No, we don't remove the hernia. What we want to do is repair the hole, close the hole, and so that's what we do. We close the hole and we implement a piece of mesh to help with the healing in that area to create the scar. The scar is what seals up that hernia hole.
All right. There are, as with any surgery, there's going to be some risks. So we want to show you some of the potential complications. And doctor, you could chime in on really if they're very common, but some pain.
Yes.
After the surgery?
Well, of course, everybody will have pain with surgery, of course.
Not as bad when it's robotic.
Correct, yes. Minimally invasive surgery has always led to faster recovery, less pain in the short term, and less pain in the long term. The inguinal hernia repair with an open incision is a type of surgery that's had issues with pain long term. In other words, patients will have pain over a period of time. And so with the implementation of robotic surgery, minimally invasive surgery, we've had less pain. Infection is rare because it's a clean operation. We're not cutting the intestines. Really, there's no bacteria there. Scar formation can occur, of course, because we're going inside the abdomen, but we do want a scar to develop in the area. So when people say, I feel scarring, I feel hardness where we repaired my hernia, and I say, well, that's good. We want hardness to develop because that's what seals up the hernia. Blockage of the intestines is a rarity as well. Bleeding, of course, rare things that can occur. Fluid, of course, anytime you have a hernia repair, any type of surgery, you can have fluid, what we call a seroma, build up in that area, and that usually resolves with time. And you just give it a little tincture of time and that will go away. And of course, injuring any type of neighboring tissues, the bladder or an intestine can occur, of course, as well. And that was a rarity. Of course, you want to make sure you have an experienced surgeon that's operating on you.
We talked about robotic surgery. I think we have a B-roll, I should say, a picture. Here we go. We do have B-roll of robotic surgery. Tell me what we're looking at and what exactly is going on.
Yeah, so you see the surgeon, he's sitting at the console, and people say, well, is the robot operating on me or are you operating on me? No, I'm operating on you. The robot does nothing. If the surgeon doesn't have his head immersed in that console, everything stops at the bedside. So the surgeon starts at the bedside, places all these little cannulas and trocars into the patient, connects the cart, which is the robot, to the patient's arms, to the instrumentation, and then the surgeon moves over to the console, immerses himself in a 3D image, and begins performing the surgery. At the bedside, the assistants can change the instruments from graspers to cutters to staplers to suturing devices and help with regard to completing the surgical procedure. Of course, thank God here at Baptist Health, we have many robots across all our hospitals. We use it for urological surgery, gynecological surgery, and of course, we were pioneers really nationwide and worldwide in the implementation of the robot for hernia surgery.
Oh, that's fantastic. Do you do more robotic surgeries than, let's say, open surgery?
Yes, I do a lot more robotic surgery than open surgery because we can do it for a lot of things in the abdomen. We can do it for colon resections. I do it for gastric cancer. I do it for colon cancer. We do it for gallbladders. Of course, as we're discussing today, we do it for hernias. So yes, I do robotic surgery for almost everything in the abdomen.
It's funny how you said what the patient asked, which is the robot doing the surgery on me or is it you? It's always the surgeon.
Correct. It's always the surgeon.
But they're thinking scalpel surgeon, right? And we know that's a surgeon, but that's kind of like the old way. It's still done today, but that's the image of, is the robot doing it?
Correct. Yeah, it was a little easier to understand when we had laparoscopic surgery because the surgeon was at the bedside with sticks inside the abdomen of the patient, and so it's kind of more acceptable that yes, that way the surgeon's operating on me. It's a little harder to understand when the surgeon moves away. We're talking about 3 feet, 4 feet away, as you can see in that image, and the surgeon is operating through a 3D console. But this is the wave of the future. There are many companies simple companies like Google who are involved in creating robots for robotic surgery because there are a lot of patients worldwide who need access to surgical care. And so what about if I could here in Miami can help operate on somebody across the world with a robot? How about if I can help another surgeon across the world?
Goodness.
So that is what's happening. And so there's a development of robots by multiple large companies who are helping with the shortage of healthcare worldwide.
You wouldn't maybe have to travel to Haiti.
Correct.
You could actually help them from here.
Correct.
That's fascinating, Doctor. That's another hour to talk about. Which one's faster in terms of time? You have open surgery, which is, again, scalpel and surgeon opening you up, and then you have the robotic. What's the difference in time? I know recovery is faster with robotic.
Right. So, yeah, it really depends on the surgeon, the expertise. In my hands, of course, as an experienced surgeon, I can do it as fast as somebody who does it with an open incision. Of course, with somebody who's learning, there is what we call a learning curve, and, of course, they will take longer as they're beginning to learn the adoption of robotic surgery, the technology, and then subsequently learning how to do the procedure. But if you're dealing with a big abdominal wall hernia, that is going to be much faster robotically because you don't have to go through all those tissues. You don't have to open everything up to get to the hernia. And doing it robotically with a few little small holes, that's going to be quicker for the surgeon and, of course, for the patient as well.
So give or take some time, minutes, 45, an hour?
Oh, so these surgeries, inguinal hernia surgeries can be done in 30, 40 minutes.
Oh, quickly.
Yeah, very quickly. They're outpatient surgeries. They come in 2 hours before surgery, they go home 2 hours after surgery.
Oh, that's great.
And incisional hernias can be done in less than an hour.
Okay, fantastic. One more break coming up. But coming up next, we're going to be talking about all the recovery after a hernia repair and what to expect after the surgery, which shouldn't be too bad. You're watching the Health Channel, All Health, all the time on South Florida PBS. If you have a question for Dr. Gonzalez, please call us using the toll-free number, 855-796-4475. We'd love to hear from you, and be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, and watch videos from previous episodes. We'll be right back.
Don't allow your weight to threaten your health or control your future. Excess weight or obesity can cause emotional and physical health risks. But you can take control. The Your Weight Matters campaign offers free resources and tips to help you measure and understand your weight. Take the Your Weight Matters Challenge. The free toolkit prepares you to speak with a healthcare provider about your weight. Your weight does matter. Take the challenge and take control today.
Dear humans, I stand here today not for myself, but for every tail wagger, sloppy kisser, and curtain ninja. I stand here for each one of the nearly 4,100 dogs and cats killed in shelters each day, asking you to join our cause and help us make sure every best friend has a chance to meet one of their own. With Best Friends Animal Society leading the charge and your help, we can save them all.
The purpose of clinical research is to help understand how the human body works and how health and disease come about. So we want to understand what makes good health.
I think women's participation in clinical trials is extremely important because we have an entirely different set of issues, whatever body system you're working with, it's different from a man and from a child. So there are certainly differences there that we need to understand and focus and realize that are specific to women.
Science has shown and taught us that men and women are different in a variety of ways beyond the obvious differences. Our organs are different, our level of our hormones are different, we respond to treatments and medications differently. Based on those findings, every single cell in a woman or a man's body is a male or a female cell, and those cells respond differently to different triggers, to different treatments, and to the environment.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Anthony Gonzalez, Chief of Surgery at Baptist Hospital of Miami. If you have a question for the doctor, please call us using the toll-free number 855-796-4475. And we actually have a viewer on the phone right now. His name is Bob from Hollywood. Hi, Bob.
Hi, yes. I'd like to ask a question to the doctor, if I could, please.
Go ahead. He's listening, sweetheart.
Okay. Yeah, you were saying to repair. I lifted a generator last year when the hurricane came, and after that I noticed something about the size of a pea just above my belly button, and I was wondering, does that sound like it would be a hernia to you?
Yeah, of course, it's in the correct location in regard to being a hernia. And the questions I would ask you, does it go away? Does it come? Does it go? In other words, when you wake up in the morning, do you still notice it there?
Oh, yes, it's still, but there's no pain. I mean, I just noticed it. And
Right.
that's why I was wondering, the way you were explaining it on something about that size, less than an inch, would that be suitable for just a suture repair type of job?
Correct, yeah. So the first thing is we have to make sure it's a hernia. If it doesn't go in, it could be incarcerated. And of course, incarceration, as you can see, since you've had it for a year, is not dangerous. Of course, we don't want it to progress to strangulation. But yes, the smaller the hernia, the smaller the repair, the easier the repair. And so that is obviously something that we promote. You know, of course, waiting for a hernia to get bigger means a bigger surgery to have it fixed. And of course, as patients get older, becomes more complicated. But yes, it's definitely, if you do have a hernia, that's amenable to repair.
Mm-hmm. Yeah, well, I'm 62 right now, so I mean, I was wondering, would it help to do like sit-ups and to strengthen my abdomen muscles, or would that help?
No, that's not going to change your hernia. That's not going to change the fact that you have a hernia. And it's not the muscles that are weak. The hernia doesn't occur through the muscles. It occurs through the lining of the muscles, which is called the fascia. And there's no way to strengthen that fascia. So the moment you have a hole there, it's going to be there. It'll progressively get bigger through the years. But you know, sit-ups are not going to make anything better. It really not going to make much of anything worse, but definitely not going to improve your situation.
Would it hurt if I was lifting something heavier in the future? Would that progressively make it get worse, or could that have an effect on that?
Yes, definitely. So anything that increases your intra-abdominal pressure, anything that will cause pressure on that hernia, coughing, bearing down to have bowel movements, and heavy lifting, things like that will allow it to progress much more rapidly.
But you foresee that it would be more of a progression if it's left untreated?
It will progress. No doubt about that. It will progress as time progresses. Yes.
All right, Bob, thank you so much for calling into the Health Channel. Great questions that he had.
Yes.
I'm going to piggyback on Bob, and I hope you feel better soon. Sports or exercise, he talked about, doing crunches and all that. How soon can you resume sports and activities after a surgery?
Right. So I think the recovery, what we talk about with regard to recovery after surgery, I tell patients they can be up and around the same day. They're walking around. They're usually driving in a few days after surgery.
Okay.
They're back to their office work, their paperwork within a week's time. I allow exercise, indoor exercise in 2 weeks. So treadmill, stationary bicycle, Stairmaster in 2 weeks. And then no heavy lifting, nothing strenuous, nothing out on the streets. God forbid, you fall or anything like that for 1 month. So people who do heavy construction work or labor and so forth, 1 month to return to work.
Do kids bounce back faster than adults?
They do.
I mean, that's just common knowledge.
Kids bounce back.
They're so resilient.
And we really don't put any limitations on kids because, number one, they bounce back much more rapidly. Usually kids are not doing anything heavy or strenuous and so forth. We're not worried about them driving and everything else. So yeah, we just let kids progress and let them live their life.
And what about a hernia ever coming back? Possible?
Yes, definitely possible. Definitely possible. So of course, anytime you've had surgery, an incisional hernia is having a hernia in an area of surgery. So let's say you had a belly button hernia fixed and that surgeon didn't put mesh, or the repair didn't go well, or you had some issues and it came back. Now that belly button hernia becomes an incisional hernia. And so yes, hernias can come back. I gave you some quotes already that, if you have a hernia repair with mesh, it's less than 5%. But when you're repairing 1 million hernias a year in the US, that adds up. And of course, there are patients who have hernias repaired without mesh. Let's say we have a strangulated hernia. We have hernia with dead intestine. We're not going to put a piece of mesh there. Why? Because there's infection. There's dead intestine. And so if you can't put mesh, right away the patient has a 60% chance of having that hernia come back. Right. So hernias can come back.
And in terms of prevention, we have a graphic to show our viewers in case you don't want to get one, and I don't think anybody wants one. Here's some things to keep in mind. Don't smoke. It's always up there. Numero uno, maintain a healthy body weight. That's important, doctor.
So, of course, smoking, we talked about that because of the fact that the chronic cough. Of course, you've heard here many times on the Health Channel all the issues with regard to smoking in your heart and so forth. So definitely smoking is out of the question. Stop smoking. Maintain a healthy body weight because of the obesity. The intra-abdominal obesity will put pressure on the hernia. Of course, constipation. If you're constipated, then, of course, talk with your primary physician. Talk to your gastroenterologist, begin some stool softeners. If you've not had a colonoscopy and you're over the age of 50, you need to have your colonoscopy to make sure, God forbid, you don't have anything in your colon that's obstructing and causing the constipation. Of course, don't lift heavy objects, and if you're going to lift something, be careful with your back. As we talked about, you're more likely to injure your back lifting something heavy than developing a hernia.
All right, so we've talked so much about hernias in this hour. We've learned so much, the A through Z, if you will. If someone just joined us right now, doctor, and they are, thinking, I think I have one, can you just kind of recap the do's and don'ts in case you are potentially at risk for one?
Yeah, so I think some of the do's is see what you feel. If you feel a lump or a ball, see if when you lay down it goes away. If it goes away, then you are suspicious that it's going to be a hernia. If it goes away, you're knowing right now that it's not a mass that you have, God forbid, a tumor or some type of growth. Seek medical attention. Start with your primary physician. A lot of primary docs can tell you if you have a hernia. If they're not sure, they'll send you to have an ultrasound or a CAT scan. And if they're still not sure, a lot of them will send you to an expert like us, an expert that can examine you. And as we mentioned, a lot of times just a simple examination, standing and laying down, can make the diagnosis of a hernia. And then if the hernia is impacting your life, then of course you get surgical care for that.
Your patients must love you. That's all I'm going to say. We
Thank
started
you.
off the show by talking about how special he is, not only as a surgeon, as a doctor, but as a special man who goes to Haiti probably once or twice a year. Your next mission is in February of 2019.
Correct, yeah.
The organization is called?
Living Hope Haiti Christian Mission, affiliated with Baptist Health, and we take a lot of people from Baptist Health with us. We've been going for 12 years. We go 3 times a year, and we do a lot of hernia surgery, but we do a lot of other things as well. There's a big need in Haiti, and so we do a lot of other types of surgery.
And not because you have to, but because you want to.
We love it. Definitely.
God
Thank
bless you.
Pleasure.
Thank you
Olga.
so
Thank
much,
you.
Doctor. Hope to see you soon. And be sure to join us next time on the Health Channel, All Health All the Time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. You can also visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, watch videos from previous episodes. It's a fantastic website. I'm Olga Villaverde. We'll see you next time.